had two major abstracts about the use of abiraterone used up front in patients with metastatic disease and castration-sensitive disease. And we also had some interesting abstract presented about the role of sequence or continuing active drugs beyond progression, and also some data about biomarkers. I had the privilege to present the results of LATITUDE yesterday here at ASCO. And LATITUDE was a phase 3 trial testing the role of abiraterone and prednisone in men with de novo metastatic prostate cancer. So basically, those men represent probably 5 to 10% of patients who are diagnosed with prostate cancer across Europe, but they're clinically very important because they represent probably half of the death due to prostate cancer in the continent. In LATITUDE, we basically were trying to improve patients' outcome for these men. The standard of care had been androgen deprivation therapy for basically 70 years until 2015, when 3 trials could demonstrate the role of the stem cell when used on top of castration for improving progression-free survival and overall survival. In this trial, LATITUDE, we tested the role of abiraterone, and because the trial was designed and fully accrued its planned target patients population before the trials testing the stem cell had read out, it was a straightforward comparison of androgen deprivation alone or plus placebo, or androgen deprivation plus abiraterone and prednisone 5 milligrams. We had 2 co-primary endpoints: overall survival and radiographic progression-free survival. This was a global trial with 1,200 men. They were selected as having high-risk criteria, 2 criteria minimum out of 3: high glycemic score, multiple bone metastasis, or visceral metastasis. So what I presented yesterday were the 2 co-primary endpoints. Overall survival obviously is the main one, and it was clearly improved with a 38% reduction in the risk of death favoring the abiraterone arm. The median overall survival was what was expected in the control arm, a little less than 3 years, and it was not even reached in the abiraterone arm, which is just great. Regarding radiographic progression-free survival, we also observed a very significant and meaningful improvement with a 53% reduction in the risk. The medians are basically more than twice improved in terms of progression-free survival. This good news didn't come alone, and actually all secondary endpoints are met: time to PSA progression, time to pain progression, time to skeletal-related events, etc., etc. Regarding safety, basically we saw what we were expecting based on all our knowledge of abiraterone in castration-resistant disease, including an excess in hypertension, hypokalemia, more rarely transaminase increase, and slightly cardiac event increase. So I guess based on this data, I strongly believe that this is now a new standard of care for these men with metastatic de novo prostate cancer. STAMPEDE, generally speaking, is a very large and little complex trial. It's testing various arms, either in parallel or sequentially, tested on top of a standard of care which was initially androgen deprivation therapy for all men who are about to start androgen deprivation therapy. So that was true for men with metastatic disease, obviously, but also for patients with localized disease and high-risk features of relapse, or patients who were treated locally and who relapsed for PSA and who are about to start ADT. So it's a bit complex because the population varies, as opposed to LATITUDE, which is obviously much more pure. And it's also more complex because there are various arms, various hypotheses being tested. Having tested that, it's a real tour de force because the UK plus Switzerland was able to include thousands of men in this trial, so they're able to address various questions in a very efficient way. So At this Chicago meeting, at this ASCO meeting, they presented the results of the abiraterone equation. So that was ADT versus ADT plus abiraterone prednisone, again in a broader population, and they basically reported the same finding as we reported in LATITUDE, which is an improvement in overall survival and in progression-free survival, with the hazard ratio being very, very similar to the one we observed, 0.63. I guess with two trials showing that abiraterone improves overall survival and PFS in men with de novo metastatic disease, this is now a clear new standard of care. Now for patients with localized disease, which were included in STAMPEDE but not in LATITUDE, I think it's a little premature to know whether this will apply as well. And this is because basically the number of deaths in this subgroup of patients is really, really minimal. We're basically comparing 34 deaths versus 44 deaths. So it would have so big consequences changing the standard of care in high-risk localized disease that we really need to be much more cautious before switching to that. Dr. Attard from London presented at the oral session the results of a plateau randomized trial. And plateau was for patients with castration-resistant disease who had received enzalutamide and who were progressing while on enzalutamide. These patients were randomized in a 1-to-1 fashion, either to be switched to abiraterone or to continue enzalutamide and to receive the abiraterone on top of enzalutamide. So basically, the goal of the trial was to test whether continuing enzalutamide beyond progression would make any difference. And the simple answer is actually no. The primary endpoint of the trial, which was progression-free survival, was not met. There was really no difference between the two arms. So I think for now, the easy message to remember is that we should not continue enzalutamide if ever we're switching to the other drugs, especially when it's abiraterone, because it won't make any big difference, and of course you will add some toxicity and of course some cost. We all want precision medicine to arrive in prostate cancer, because if you think about it, among the 4 big cancers in Western countries, prostate is really the exception. We're using precision medicine in breast cancer, in lung cancer, and in colorectal cancer, not in our routine for prostate. 2 to 3 years ago, we had some big hope about a given biomarker, which is the androgen receptor V7 variants. And it's a version of the androgen receptor that makes the receptor constitutively active, and doing so, it was predicted that enzalutamide and abiraterone would not work. Actually, based on that, a trial was designed where these patients with castration resistance were tested, and patients with positive V7 variants in their cancers were randomized between enzalutamide, which was expected not to work very well for this particular subgroup of patients, versus galeterone, which was found in a small set of patients to be perhaps active in the subgroup of patients as well. And actually it's not the case. What we saw in the trial was that first, the number of men with positive V7 variants in their cancer when they're just starting to progress while on castration is quite rare. Second information, it's really, really bad disease, very aggressive disease, and this is quite clear. But when they're being randomized between enzalutamide and galeterone, it doesn't make any difference. And actually, there were some responses observed in the enzalutamide arm, and actually there were not much more in the galeterone arm. So probably it's going to be the end of galeterone, because the biological hypothesis is basically not met. So we'll need to find new biomarkers. The androgen receptor is probably much more complex than what we originally thought. Probably the number of copies is important, mutations are important, and we need to integrate that a bit better before we can have that ready for prime time for a routine practice. Now, regarding biomarkers, perhaps DNA repair defects might be the one that will come out hopefully quite soon. The main take-home message obviously is that the standard of care for men with de novo metastatic prostate cancer is now being changed. We can now use abiraterone prednisone, assuming of course all the society will approve a drug in this indication and a reimbursement will be agreed on. But truly, given the efficacy data that we reported at this ASCO meeting, on top of a very favorable safety pattern, I think this is going to be the new standard of care. Now, the new question will be, should we use both chemotherapy and abiraterone for these men? And this is the exact question we are currently asking in the currently recruiting PEACE-1 phase 3 trial. And I'm happy to say that we're about to reach 800 men already randomized in this trial. So hopefully in 6 to 12 months from now, we'll be able to complete the accrual and we will have the data in a couple of years from now.